Hi everyone, this is part 2 of CT. This is continuing on your CT lecture that we left off in class. We are on chapter 29 in your Merrill's book. Okay, the image quality factors that affect CT images are spatial resolution, so detail, contrast resolution, that's black and white, the temporal resolution, that has to do with time, okay, noise, so grainy versus nice images, and artifacts, and that's just making sure that your images are free of all artifacts within your reason. Okay, so first thing on the agenda is spatial resolution, and that is, they describe it as blurring in the image. You can remember that as detail in your image. Okay, just like we use a small focal spot in an X-ray tube, we will likewise do the same in CT, and that tube is set up automatically due to your protocol that you select. Okay, so spatial resolution or detail is affected by focal spot size, the slice thickness that you program the computer to reconstruct, your display field of view, your matrix that you are choosing to use, and then the reconstruction algorithm. So for instance, the abdomen CT would be reconstructed in a standard algorithm so that your images are in between. They're not too detailed, they're not too blurred or unfiltered, they're not too black or not too white. So that's standard algorithm. You have a detailed algorithm, which is usually called bone. And if you are x-raying bone or CTing bone, like a wrist, you would use a bone algorithm, and that gives very sharp detail. Okay, and then you have things like an algorithm that you can use for soft tissue to see things in the soft tissue better. You have lung algorithms that you can see lung tissue better. For instance, in this picture up here on the right, you're using a lung algorithm, and that helps show those lung markings more detailed than you would with a regular standard algorithm. So all of those things will affect spatial resolution, which again is defined as the ability to make out small objects in an image. It's usually measured in line pairs per centimeter, and that has to do with the QC, and we'll touch briefly on that as well. Okay, the detector aperture width. So that's just the width that you program the CT scanner to use. Okay, this is the most significant geometric factor of spatial resolution or detail. Okay, it is not good. CT spatial resolution is not as good as conventional radiography. I think with the technology the way it is now, you can make it really good. So that's debatable. Okay, so the pictures up here on the top right are just showing how dose affects your resolution. Okay, and it's the same with X-ray, so I don't see a big difference there. And the bottom two square objects here are what the CT phantom looks like. So this is one picture that you would get when you do CT QC. And what you do is you count how many line pairs that you actually see in each of the squares, and the ones that you can make out best. And that shows what your resolution, your spatial resolution is for that. For instance, A is a standard algorithm. So your line pairs end right here at the bottom. Those are the clear line pairs that you can count. But if you look over at B and you look at the bone algorithm, there's more detail. So those line filters go all the way up around to the 2 o'clock position over there. Okay, so there's a difference there in your detail. Okay, the next one is contrast resolution, and that's just the ability to differentiate between small density differences. Okay, so black and white. In the CT QC, how you can tell if you have good contrast resolution is by counting the number of spokes that you see down on this bottom image here. There's 4 images. You can see in this one on the left that you can count these spokes of circles all the way around. You see all of the spokes present in that image. But if you look at the one on the far right, it's much harder to ascertain where those spokes are. So you have lost some contrast resolution there. Okay, so CT can distinguish between these differences of 0.5% or less. Okay, this image here on the top right is a CT brain, and it just shows you the difference in contrast resolution. This one on the left has a lot more contrast resolution than the one on the right. Okay, contrast resolution is affected by your slice thickness, your reconstruction algorithm, which is what we talked about, standard versus bone, things like that. Your image display, so if your monitor is not set appropriately or calibrated, it's going to affect your contrast resolution. And your X-ray beam energy, so just like X-ray, if you have more photons making the picture, you're going to have a better, clearer picture than if you're not using enough dose. Okay. Also, the patient size and your detector sensitivity. So remember, we talked about gas versus solid state detectors. They can also have a direct effect on contrast resolution. Okay, next is temporal resolution, and this is mainly of concern when you need to do cardiac studies. It is definitely dependent on the equipment type that you have and the software that you have. So since it's used for cardiac studies, you're looking at multi-detector CTs. 128 is where they're going right now with it, although there are 256 and 320 slice machines out there. The tube and gantry rotation time is also a factor that is necessary to improve temporal resolution, faster gantry rotation times. And then again, dual source CT will help your temporal resolution. Okay, and if you've done your reading, you know that that's a 6th generation scanner, dual source CT, right? Okay, noise. The most common cause is quantum noise. Gives the image a grainy or mottled appearance, and your contrast resolution is the primary image quality factor that is affected by noise. Okay, and there's 2 pictures here. The top is an abdomen. They're both very, very grainy. This can happen with very large patients, although this patient picture here is not large. They've obviously not used enough dose. But sometimes when you have patients that are very fluffy and you put them in the protocol scanner, if you forget to modify the protocol and increase your dose manually, you can get these grainy appearances. And it's very unlikely that you're going to be able to get diagnostic imaging out of them, so you're going to have to get the radiologist on board to rescan. So that's something CT techs really need to be cognizant of, you know, is looking at the parameters of their protocol before they hit that scan button. Okay. Okay, noise. The scan parameters that affect noise: your matrix size, your slice thickness, of course your X-ray beam energy, and also, believe it or not, your reconstruction algorithm. So you can have a decent looking picture and in the standard algorithm, which just means you've used plenty of dose, you had a decent matrix, your slice thickness isn't too thin, and you have nice pretty pictures. But then you go in and you change that algorithm to one that's more detailed, like bone, and now you've got a noisy image, okay? Because the bone algorithm, it's so detailed, it needs more energy to make up the difference, or you need to change your matrix size. So you need to manipulate those parameters depending on which algorithm you're using. Another big factor for noise, of course, is patient size, just like an X-ray, and scatter radiation, okay? Next, we're going to talk about artifacts. So artifacts can be prevented up to a point, okay? And the artifacts I'm talking about are getting them off the patient, so changing your patient out, making sure they remove metallic objects like earrings and piercings, and things like that. Not doing a CT scan if they've just had a barium enema or upper GI, because the residual barium causes streak artifacts, just like metal. So you would do a CT prior to a barium study if it was a scheduled exam. Otherwise, you'd need to wait a week to get that barium out of there. Okay. Also, large tissue density differences can cause streak artifacts. Okay, so skull, the bone of the skull going into the soft tissue of the brain. So the base of the skull is really thick bone, and that can cause a streak artifact. So a lot of times in CT imaging, you use different parameters for the base of the brain, where the skull is thickest, and you decrease your dose when you go up, or you decrease your MA and your KBP as you go up into the vertex of the brain where there's less skull. Okay, other things that cause streak artifacts. Dental fillings will cause them on skull imaging. Pacemakers will cause them in chest imaging. And your artificial joints, like this image above, is bilateral hip replacements. There's nothing you can do about that in CT except for increase your KBP a bit. Okay, that has been shown to reduce metal artifact as much as it can be reduced. Okay, this bottom image of the abdomen is what residual barium looks like. So it just does a metal type streak artifact. Okay, here's another thing of CT artifacts. So this top one, A, is a phantom, and it's showing a streak artifact. So most likely in something like this, since a CT phantom is calibrated and perfect to not cause a streak artifact, you have something on your tube lining. The clear lining, barium has either dropped on there or something is inside there that's causing this streak artifact. Okay. B is the streak artifact that's caused by bone into the skull imaging. Okay, C, I don't really see any artifact here. This is what bone looks like. It does have the algorithm on it for bone though, okay? D, that's an artifact, that ring that white arrow is pointing to that makes those dark lines. That's called a ring artifact. That happens with a bad detector. That's how techs know there's a bad detector, and that's when you call engineering. And they come and figure out which one it is and replace it. Okay. E also has a detector, a bad detector artifact. They're subtle, so yeah, good tech needs to look for those. And E is dental fillings. Okay, again, here's some more ring artifacts that show up. And this is a really bad one right here. So these, you know, this is a bad detector array or something's happening. Okay, other image quality factors, of course, are motion. So A and B show degraded images because of motion. Okay, size of the patient is another image quality factor. Okay, if they are just too big or too small. Okay, and you have the wrong technique or you're maxed out on technique. Okay, so scan times are usually preset by the protocol, but we can alter them. The shortest scan time reduces the chance of having someone move, okay, especially with pediatrics. You need to just really scan as quick as you can. Okay, and this is showing a scan diameter. It's the field of view, okay, it's called the scan field of view. And we had mentioned that the diameter of that gantry, the aperture in your CT scanner, is usually about 70 cms, okay? Most scan fields of view in CT are 50 cms. So even though your patient is not 50 cms, the information within 50 cms of the isocenter is going to be taken as the tube rotates around, and that information is projected onto the detectors, okay? Well, you can adjust that. So for a head, you wouldn't need 50 cm scan field of view. So you can adjust that down to, say, 25, okay? But that can be adjusted, but that is what the scan field of view is doing, okay? Special features of CT. So we're moving on to what CT can do. Examples are dynamic scanning, okay, spiral CT or helical, multi-slice CT, CT angiography, 3D imaging, radiation treatment planning, and PET CT scanners are just a few of the things that we're going to touch on. Okay, dynamic scanning, and that just means that you have injected the patient with a bolus and you're going to take pictures as the patient's vascular system processes that bolus. Okay, so you're going to be looking at arterial flow, you're going to look at venous flow, You're going to look at delayed images, and usually you look at pre-injection flow, okay? So this is based on the principle that structures will enhance at different rates after contrast administration. Two forms of this. There's rapid sequential scanning at the same level to observe the contrast filling at a particular structure. That's usually called perfusion scanning, okay? And I'm sure you might have heard about perfusion brain scanning, and that is where you take a picture at the same spot over and over again and inject contrast to see what a brain tumor is made of. The radiologist can ascertain that with the amount that it's filling and at the rate it's filling, okay? CT perfusion scanning is no longer industry standard due to radiation dose. I don't know if you remember the Cedars-Sinai incident, okay, but it showed that there was some residual radiation effects on those patients that were getting perfusion imaging. So hair loss that was permanent, they were getting radiation burns, so they were getting all of the signs of radiation poisoning, okay, from perfusion scanning and CT. So that is not industry standard anymore. MR perfusion scanning is, okay, because of the lack of radiation there, and they can still get good images. Okay, so that's rapid sequential scanning. The kind of scanning that's most popular is incremental dynamic scanning, and that's where we do several different serial scans, one after the other, at consecutive levels, just meaning we start at point A and we go down to point B. So, and we do that several times in a row. Okay, helical CT. So we had mentioned in class that there's two types of CT scans that you can do with your scanner. You can do axial scanning and you can do helical scanning. Axial scanning is more detailed, so you use those for detail, like in head imaging or specific vertebral body spine imaging, okay? And A just gives you some pictures of axial imaging. By the way, you also do axial imaging for high-res chest scans. So the industry standard right now for a high-res chest is you take a regular CT scan of the chest with them holding their breath, and then you take axial slices, about 10 up at the top apices, 10 in the center, and 10 down at the bases of the lung tissue, and that will give the radiologist the information that they need to make diagnosis of interstitial lung disease. So that's another example when we use axial scanning and CT is for the high-res chests. Okay, but moving on to helical CT, newest method of data acquisition. It's been around for a long time, okay? The gantry rotates continuously while the table moves through the opening, okay? This continuous motion of acquiring data forms a spiral path, and this is giving us all the raw data from point A at the bottom of the neck all the way to point B. So it's a continuous amount of information that can be reconstructed into any image at any point in the body from A to B that you've scanned. So anywhere on the grid, X, Y, Z, you can make an image of that area, okay? Slip ring technology is what makes this possible. Okay, this is another image of helical CT. Okay, and I noticed in your Bouchon book that he does not like the word spiral. And he kind of shows you a picture of what a real spiral looks like and why this is really not spiral, it's helical. So we'll call it helical in his honor, okay? It scans a volume of tissue rather than a group of individual slices. The advantages are your respiratory motion is minimized. The advantage of any kind of motion is minimized. It's useful for the detection of small lesions, and that's because if you did axial scanning, you might miss a small lesion. You might not take a picture of that one little area. Okay, it's useful for scanning uncooperative, combative, trauma, and pediatric patients because, like I said, you're getting this continuous amount of information. All of the information from point A to point B is there, and you can reconstruct it. Okay, it also decreases the amount of contrast, which increases safety and decreases cost. Okay, now decreases the amount of contrast. We're going to have to talk more about that at a different time. Okay, so multi-slice helical CT. So multiple rows of elements or detectors along the z-axis compared with the single row that was in conventional CT. The advantages to this include isotropic viewing, okay, so that you can get a full square of information, and you know that there is no distortion within that square of your matrix, okay? Longer anatomic coverage, multi-phase studies, faster exam times, and improved spatial resolution. So this is all advantages of putting more rows of detectors to get that information as it's scanning so that you have more information to play with. That's pretty much all it comes down to, okay? And this is just some more images of what we take pictures of, and as you can see, there's a pretty big lesion in the liver, okay? And the fact that it's not filling in that delayed phase, we would do another 10-minute delay. We just leave the patient on the table to make sure that doesn't fill. If it does fill, it would be a hemangioma, which is benign, no worries. If it doesn't fill, we got a problem. Okay, so volume CT. 64 rows of elements in the detector rays. Okay, so that's a 64 slice. It will image an entire body section on a single breath hold. And cardiac imaging uses volume CT. Okay, so let's go into CT angiography. So the application of helical CT uses 3D imaging techniques, okay? It allows visualization of the vascular system in 3 dimensions, replacing conventional angiography for some studies. Matter of fact, it's replacing them for a lot of studies. Runoffs, things like that can be done in CT. They're fast. They're usually much easier on the patient. Okay, because it's a normal just IV stick. And the images are beautiful. Now the dose is up there, but the images are beautiful, so the doctors have to outweigh the risk versus the benefits. Okay, there's several advantages over conventional. The reconstruction capability from one data acquisition without the additional contrast administration, so we only inject once and scan and that's it. Overlying the anatomy eliminated so other vascular structures can be seen. So in the IR suite, you're taking conventional radiographs and looking at those images unless they have the software like CT does to map out those images. The difference with CT is since we're taking these pictures in a 360-degree angle of all the body parts, we can map out the bone and just leave the vessels, and using their software, grow them into 3D structures, okay? It does not require an arterial puncture, so there's less risk, okay? Okay, 3-dimensional imaging. So this is all part of post-processing, okay? So this isn't a great picture because I blew it up to put it on this slide, so now it's not sharp. But if you could imagine it sharp, this is just from a CT angio scan. And what we've done with the software is we've post-processed it, we've made it in color, and we've taken off all of the anatomy that we don't want. We just wanted these lower vessels so that you can see the femorals, you can see the iliac bifurcation, and you can see the aorta, okay? So, and these you can rotate around, so the radiologist can get really great images with these. Okay, the common techniques to make 3D imaging are MIPS, maximum intensity projections, SSDs, which are shaded surface displays, and volume rendering. The post-processing is always done on the raw data. So remember I told you in class, if the raw data is gone, you're out of luck. Okay, so all of these post-processing usually needs to be done within the first few days after the scan to make sure that the raw data is still available to do anything that the radiologist needs you to do. So, matter of fact, you know how you have CT protocols to scan patients, you also have protocols of what to do with post-processing. So that's usually done by the 3D lab, done right after the patient has been scanned or within the next day or so. Okay, it creates realistic images of the surface anatomy. All techniques use the same 3 initial steps. It's construction of a volume of 3D data from the original 2-dimensional CT image data. The segmentation, to crop or edit target objects from the reconstructed data. So the software lets you cut out areas that you don't want. So you can draw a line around a structure and tell the computer to erase everything outside of the line, everything inside the line, whatever you prefer to get your image done. And that'll eliminate the unwanted information from the data. And then rendering or shading, it provides depth perception. So you can actually grow vessels. You can tell the computer to add shadow to make it look like a better image. And usually that's what the radiologist will do. Maximum intensity projections, or MIPS is what we call them, uses the brightest pixels from the 2D or 3D data, commonly used for CT angiography. And what it's doing is just taking the information that you have in your raw data. You tell the computer that you want it to make coronal images from the top of the diaphragm all the way down through the pubic symphysis. And you tell it you want it in the coronal plane and you want it to be at 5 millimeter thick slices, so you want 20 slices. And it comes up with 20 coronal slices. It just takes the data, it compresses it all, and gives you your coronal images that you want. So those are called maximum intensity projections. Shaded surface display takes the 3D model that you've made and shades it in. It fills in bone, it fills in structures, it makes 3D models, and you can rotate these around. So it sets a threshold value for a particular CT number. Any pixel having the equal number that you pick or higher, then the threshold value that you select can be used for the 3D image. It gets rid of all of the rest. So you can pick the actual CT number that you're looking at. So like bone, you tell it you want it to map out things that are 950 to 1000. Everything else disappears, and that's what's left in your image. It provides depth perception to a reconstructed image. Volume. Okay, this requires powerful computers to reconstruct the 3D images. Otherwise, it'll take forever or hang your system up. So you have to have a good, powerful system. It takes the entire volume of data and makes it into a 3D image. So, for instance, this looks like they've done a shoulder. They're looking at the clavicle, which is broken here. So they're doing 3D volume rendering to look at that clavicle from all views. Any plane that the radiologist wants to view it at. And that's going to show him any relationships anatomically with the other bones or junctions that it's sitting next to and any vessels that might be near it. Very cool. Okay, another application for CT is radiation treatment planning. Now this is done locally. We used to do these all the time in our CT scanner. The radiation treatment people would come on over with their form, which is just like, depending on the body part that is needing treatment, it could be a mask for the face, it could be a chest mask. And what the form does is once the patient has the form on and velcroed around, it holds them in the same position for every single radiation treatment. So most people have to go through several treatments, if not a dozen treatments. And having a mask or a form makes sure that that patient is in the same exact position each time. So what they do prior to treatment is they make the patient form or mask. They bring the patient over to the CT scanner, they put that mask on, and then we scan them in CT. And that scan gives them anatomical landmarks in addition to the form around them. And you can map those out. You can do 3D images for the radiologists that are doing the treatment. It aids the dosimetrist in maximizing the dose to just that target. It knows how deep they have to go. I mean, it is great, great stuff for patients that need these treatments. Okay, and then lastly, PET and CT scanners, okay? I worked on the Siemens Biograph 16 PET CT scanner, which means it's a 16 slice scanner. So we didn't do, big angiography scans or heart scanning on it, but it can do pretty much anything else. Okay, we even did runoffs on it. If the patients refused to go downtown, we would still do them. So it's a very decent diagnostic CT scanner. In addition to having a CT scanner, which is right here in the front, you can see on this picture, right there in the aperture, this black ring, that is the clear sleeve that the photons go through for your patient. So your X-ray tube is housed right here in this green ring and your detector array. But what you don't see in this picture is that the gantry keeps going for about 5 feet. Okay, so the PET tech can use the CT tube to take an image of their patient from head to foot or whatever they're scanning for PET. And that image, it's not diagnostic CT because they're not CT techs. Some of them are, but most of them are not. So it's not used for diagnostic purposes, but what they use it for is to fuse it over the rest of their PET images so that they have great anatomical bony landmarks of the body part that they fuse over the PET images as they are being post-processed. And then the radiologist can use all of those bony landmarks to make the diagnosis. Okay, quality control in CT. This ensures that you are taking the best possible pictures for your patients. So this is done usually on a daily basis. It's common for the CT tech to come in and the phantom is already set up by the tech who closed down the scanner the night before. Okay, the CT tech comes in and fires up the machine, landmarks on the CT phantom on exactly the crosshairs where it's supposed to landmark, and there's a protocol for QC set up where it takes 3 images at certain intervals. The CT tech then can look real quick through those images to make sure that there's no ring artifacts, no streak artifacts that they see, and to make sure that they can count the spokes and the line pairs like in those images that we saw previously, to make sure that everything's working the way it should. And if not, call the appropriate engineer or physicist. Okay, dose reduction hardware. And this is versus software. There has been dose reduction software on CT scanners for many, many years. And every single manufacturer has their own version of it and calls it something, different. But this is dose reduction hardware, where the manufacturers are actually developing new hardware to reduce patient dose. And like I said, CT imaging got a little crazy where everybody was ordering CTs. And now they are seeing how that has increased patient dose significantly in the past 10 years. And now they're trying to rectify that. So these are some ideas from equipment manufacturers. One is called the off-focal radiation suppression devices. They also are looking at beam shaping filters. These are going to be like your wedge filters, things like that, but used them for CT. Your Z-axis efficiency with increased collimation. So they're just changing collimation, making it better. And improved data acquisition systems. So these are just going to be advances in technology of the detector, how they acquire the information. They can make great pictures even with less information because they're much more sensitive. Okay, and the software can do a lot more. Dose reporting. Okay, this is very important in CT. Okay. Patient dose must now be part of the permanent record for each examination, believe it or not. It did not used to be. Okay, so now when you take a CT scan of a patient, every single manufacturer has a page that has the dose that that patient received for the CT. It is broken out into the axial scans. I call them axial, but they're actually the transverse scans. These were done helically, okay? And this second series 2 was the first helical scan that they did from S15, which is where it was landmarked, down to I650, and that dose was 373 milligrams per centimeter, okay? The second helical scan was from S188, so they went higher, to I105, and that dose was 182 milligrams per centimeter, and that you see right here, okay? And then the total dose for this exam, 555.72. Notice up here on the Scout, they do not need to record the Scout. That's just like your AP X-ray, okay? So the most common reporting method is your DLP. It goes straight into PACS. Okay, if it doesn't, then your radiologist must list the dose on the patient's report. Most places now do both. The radiologist puts down the dose in the report. That's usually done automatically now with our systems, and the rad doesn't need to read it out loud, but if they notice the system is not filling that in, they have to read it out loud into the report. And number 2, it's in PACS. It's part of the images that come over to PACS. Okay, just a little mention on this CDTI volume right here. What that is every slice that was covered. So what every slice that was reconstructed out of this helical scan, the system has averaged that the radiation dose for just those slices, each slice was 5 milligrams, 5.1 milligrams. Okay. Okay, CT versus MRI. Look at that. The initial introduction of MRI raised concerns that CT would become obsolete, and now we know that that is not the case, and it's never going to happen. CT is much too valuable a tool. It takes images very quickly. It gives beautiful images of bone and soft tissue, although MRI is better for certain soft tissue. However, for vascular imaging in particular, CT gives gorgeous pictures. There is radiation involved though, so you have to weigh these things. Okay, CT does demonstrate bone better than MRI. Okay, so it's still utilized for fractures, etc. Okay, patients with metal in their bodies also should not be scanned in MRI. And even if it's metal that's not contraindicated, meaning it's not ferrous, it's not attracted to magnets, if you are scanning that area, that body part, then they should not be having an MRI. As you can see in this top picture, metal and MRI does not mix. So it just makes a big void artifact where you don't have any data at all. Okay, this middle picture is just a CT scanner, the one on the left, regular GE CT scanner. The one on the right is the MR scanner. So there is a claustrophobia element involved. There's also much longer MRI scan times. About the shortest MRI scan that you're probably going to have out there in a diagnostic imaging facility is in a half-hour time slot. That is because the students need, or the patients need to be changed out. You don't want to take any patient clothing into MRI if you can avoid it, because people have stuff in their pockets that can be attracted to magnets, and it's very dangerous. You can also need to screen them to make sure that they're safe, and these things all take time. Then to acquire the images, it is lengthy. So the shortest one that you're going to acquire is probably 15 to 20 minutes, and that's just because you do certain images in MRI that are required, and it usually takes about 4 sequences, and each sequence can take anywhere from 2 to 7, 8 minutes long. Okay, so a lot of patients cannot tolerate MRI, and CT can be less costly. So as a note, I wanted you to look at these little images down here on the bottom. This is a lumbar vertebra. okay? And then the one on the left here and the one on the right here. The one on the left here is an MRI scan, believe it or not, okay? So you see the fluid here, the spinal cord, the broken vertebral body. You see the kidneys really good. You see all these muscles going through really good. And you see the spinal cord really good. But what you don't see really good is the fracture of the bone. When you come over here to CT, it is gorgeous. Look at those fractures. So they're all right there. Okay, so CT is very useful for that kind of thing. Okay, so to wrap it up, the number that is related to the linear attenuation coefficient of the tissue within each voxel is, and the answer is B, the CT number. Okay. All of the following affect the radiation dose delivered during a CT scan except, so KVP we know does, MA we know does, the section or slice thickness we know does. 3D reconstruction we know does not, because it's always done after the fact, post-processing. So the answer would be D. Okay, which of the following might cause artifacts in a CT image? Dental fillings, scars, pacemaker, artificial joints. So the answer would be A, dental fillings for sure. Also C, the pacemaker, because it's got a metal component. And D, the artificial joints, and we saw pictures of all three of these things. Okay, the midpoint of the range of gray levels to be displayed on the monitor defines window level, window width, speed point, or contrast scale. So we know it's not speed point, we know it's not contrast scale. So the midpoint of the range of gray levels. The gray levels, the width of it, the window width is that whole width of gray. So all of the grays, shades of gray. The midpoint of them is the window level. Okay, so the answer to this is A. Okay, which of the following affects spatial resolution of a CT image? And that's detail. Remember we talked about spatial resolution is equal to detail. So focal spot size, slice thickness, field of view. I would say it is all three of those things. Okay, and that's all we have for today. You guys have a great weekend. See you on Monday.